Hi, my name is Dr. Mike Pekarsky. I'm a doctor of physical therapy. On social media, I'm also known as Dr. Kickass. I'm going to use this opportunity to explain some of my thoughts a little bit more thoroughly than I would be able on typical social media platform that limits how much content I can put on. Today, I'm going to answer a question that I often get, which is I have an injury. What do I do? So when someone has an injury, there's generally several questions that people want to know. First one is what kind of injury is this? And to determine the type of injury, someone's going to need to see a rehab specialist. They're going to need to give them a history of events, and they're going to need to undergo some kind of physical examination. From there, then the healthcare professional can develop an assessment of what is going on. Next question is, will this injury heal on its own? And that's follow that assessment. Then the rehab specialist can give their prognosis. In many cases, injuries do heal on their own, such as muscle strains or mild ligament sprains. That being said, stuff like complete ACL ruptures will not heal on its own. And then there's another issue, which is when someone has injury, there's going to be some kind of tissue damage. Your body's going to heal and create new tissue. Well, that new tissue is still weak, unorganized tissue that essentially has to go through a course of time before it remodels and becomes stronger, resilient tissue like it was before. Uh, During this time, people may start moving differently from pain or some kind of mobility restriction, which will then develop other areas to compensate for this issue. So, um, when someone comes to me and they say, do I need to see someone? Well, really, like I said, it depends. The sooner someone comes to me, the faster that we can usually address it, because acute injuries we can kind of just deal with the injured tissue, we can then prepare it and then strengthen it. Versus if this becomes a chronic issue, something they've been dealing with for a long time, they may start to develop a lot of compensatory motions. Next is who can perform rehabilitation. I would usually say that the best bet for rehabilitation would be going through a licensed professional, someone like a licensed therapist, chiropractor, or athletic trainer. In the U.S., most states have something called direct access, where you can see the rehab specialist before needing to see the physician. Uh, I would make sure you look into your state to know. In the state of California, I can see a patient for 45 days or 12 visits before they need to get a referral from the physician. This may also depend if you're going to see a rehab specialist, which is accepts insurance, or if they're cash based. And that's why this is also a team approach, because especially if it's an injury where it might involve a surgeon, you're going to have the rehab specialist, you might have a strength coach, you might have an orthopedic surgeon, and then the actual skill coach. So this is going to be a team approach for the athlete to completely rehab their injury. Next step, which is how long will this process take? Well, this brings us back to the assessment, which is once the rehab specialist has identified what they think the problem is, they can look at the physiology of tissue healing of the tissue that's damaged, and then also decide other impairments that the person has. Sometimes there's other compensatory responses. Maybe there's some kind of muscle weakness. Maybe it's movement retraining. So it really depends on how many different impairments that are directly involved to this injury to know how long the process will take. Next question is, will I need surgery? And this brings us back to the team approach, which this is a complicated question, which will be determined follow the assessment, which I'm going to get to in a later slide. And then the last question is, when can I return to sport? I know that most athletes that I deal with in combat sports, generally something hurts. Once it stops hurting, they go back. I would generally say that this is not a good process, because just because something doesn't hurt anymore doesn't necessarily mean that they're ready to go back to the rigors of their sport, especially something where um, there's a lot of explosive, quick motions. But again, that question will be answered in a later slide. So the first step is to get an evaluation. The point of the evaluation is to gather data. The first job of the evaluation is to identify the specific pain generator. So if someone's coming to me and they have some kind of pain, I need to know exactly what's causing that pain if I'm going to treat it. Next is to establish the individual's functional capacity. This is important so we know any potential compensatory issues that could be contributing to the pain generator or something that might make their prognosis worse. This is where someone will be able to identify individual impairments, which will be then discussed more in the assessment. And then the last point of the evaluation is to determine if this is in fact a musculoskeletal issue or not. If it's not a musculoskeletal issue, so somebody can have pain for other reasons, whether it's something more serious like cancer, or it could be a medication side effect, it could be some more psychological component. Those are people that they need to see other healthcare professionals that are more able to treat that issue. Next step from the evaluation is to get the subjective. So the subjective is essentially the history of the individual and their specific injury. So important thing that needs to be determined was the mechanism of injury. So how did this actually happen? Was it an event or was it something that just got worse over time? Is it a next thing we want to know is the duration of the injury, which is how long you've been dealing with this. Is it something that's acute, like did you just roll your ankle last week, or is this something that you have a history of ankle sprains? Because even though it's a similar complaint, I'm going to treat those differently. Next is back to previous injury. And the reason why this is important is because previous injury is the number one cause for re-injury. So if again, someone's coming for an ankle sprain and then I find out that they have a history of ankle sprains, it could be that one, they have an acute issue that ankle ligament is compromised, but also the fact that they've been dealing with this for a long period of time, likely that ligament never regained its full resiliency, and that they may have developed other compensatory patterns. Next would be to rule out red flags. This is like I addressed in the last slide, which is I need to make sure that somebody is actually here for a musculoskeletal issue and it's not from something else. This is also will figure out if someone has any diagnostic imaging or if they need diagnostic imaging. In some cases, diagnostic imaging is the gold standard to identifying the issue. In some cases, it's not. It depends on what the issue is. Sometimes people will have diagnostic image that's going to tell me stuff that's more just noise. It doesn't really solve the or help determine the issue, because diagnostic imaging focuses on macro trauma, like big tissue trauma, versus micro trauma, which is more of just smaller tissue things that may be developing, that may have developed from compensatory motion. And then last is I want to know what their goals are. So let's say someone says, I have a knee injury, I want to get back to jiu-jitsu. I need to know what their goals are so I can identify what it takes to do that goal. I know usually people say, my knee hurts, I want the pain to go away. But really, the most important question I ask people is, what is this knee pain stopping you from doing? Because we really want to focus on function. Pain usually isn't a really good goal because there's a lot of factors that go into pain. In most cases, if I can improve function, pain will go down. So the next step is the physical examination. And this is where we can actually establish that person's functional capacity. And there's usually going to be several components that need to be addressed. The first will be joint health. Depending on how thorough the rehab specialist is going to be, this could be a full body assessment, or it could be just a joint health assessment of the area that they're complaining about. I would generally encourage that even if somebody is only going to focus on the individual complaint, you still look above and below, because if someone comes to me and they have an knee injury and it looks like their hip is really either weak or is really poor movement capacity, that could be something that had contributed to the knee injury. Next is we're going to look at mobility, and the reason why is because if someone, we go back to their goals, and we have to determine, do they have the mobility to do the movement patterns required for their job or their goal. And if they don't, then we have to figure out what is actually stopping them from doing it, whether it's actual, is this back to a joint health, is it a strength thing, but that's something that needs to be determined. And that could be determined through tissue exploration, where I want to make sure, is this a tissue injury, is it a joint injury, is it a motor control injury, because those will all be treated differently. Uh, Back to motor control, this is where we look at something where how well the person can actually control their body. This also goes to a concept of mobility versus flexibility. So flexibility involves passive motion, meaning if, let's say someone's laying on their back, how far can I raise their leg, versus mobility, which is active control, just how much can they raise their leg. And this could be someone where if, let's say, there's a large discrepancy from mobility versus flexibility, that means there's large ranges of motion of their body that they can't control. That's going to be a problem. I'd put that in a motor control issue. Stability can be is a broad term. This could be something like single leg stability. This could be some kind of core stability. This could be just movement patterning, where maybe they just have poor ability to stabilize either at that joint or somewhere else. Because if someone has problems stabilizing somewhere else, it may then travel down to the injury site. I'm also going to be looking for gross asymmetries, whether it's strength and mobility. Because sometimes this could be something where um, those compensatory motions, if, let's say, something doesn't move or something weak, something else has to move more or greater, which can then overload that other area. Next, I'm going to look at movement patterns. So we can look at just general functional movements based on what their complaint is, some kind of pushing motion, or pulling, moving, their carry, how well they hinge, they squat, they lunge. This gives me an idea of how well they move when everything's together. This is also where I'd kind of put in power and strength. Some people may be fine, but they may have poor ability to generate power. And then the last component would be sport-specific movement. Whether someone's complaining about pain when they punch or kick or running or jumping, this is something that I'm going to want to look at, so I know and actually can give advice, whether it's a skill issue, whether it's a something else. So after I've done a physical examination, that's where assessment comes in. So essentially what you do is you collect all the information that you gathered, and you want to develop a hierarchy of impairments and how to prioritize. So a lot of times you might find something that maybe someone doesn't have good ankle motion, but they're here for something else, based on what their goals are and some of the movement patterns they are. It might be something where that joint might not be optimal, but it might not be the cause. Or maybe if, let's say, I'm looking at someone and they've really poor hip mobility and they're having pain with their squat and their knee, maybe that is something I do think needs to be addressed. This is also, once we have that assessment, then by this time the rehab specialist should have a good idea of the potential pain generators. And this goes back to diagnostic imaging. So usually when someone gives me an image, I look at it and I keep it in mind, and then I want to see if my exam would agree with the assessment of the diagnostic imaging, because there's many times that in diagnostic imaging there's going to be an issue that will come up. It could be some kind of disc degeneration in the back, it could be a partial rotator cuff tear, it could be a labral tear in the hip. There are these things that could be asymptomatic, that when someone has pain in that area, they do the scan, they're like, oh, I have pain, I have this pathoanatomical defect, this must be the reason why. And generally, I don't necessarily say that's the case all the time, so I want to make sure that what I find matches the image. So after the physical examination and the rehab specialist has done their assessment, then they can determine the prognosis. So at this point, they should have an idea what kind of injury is, because they've done these tests. Um, Generally, as a clinician, it is a good idea to focus on ruling out pathology versus ruling in. It's very easy to say someone has elbow pain, it's most likely this. The problem is if you go with that mentality, there is going to be times where it's going to be that other thing, and because you just went to the quick and easy thing, you could be missing something. Perfect example, someone comes to me with elbow pain and they think it's a tendonitis, and I never actually ruled it out. It could actually be something that was stemming from their neck, but since I never checked their neck and I wasn't thorough, I'm treating something that is not their complaint, and that means that their injury isn't going to resolve. Next thing, which is how long will this take to resolve? At this point, especially after tissue exploration or watching how people move and get an idea for the compensatory motions, at this point I should know what tissue is involved and then how long it's going to take for them to retrain. This is also dependent on the person. Some people are better motor learners than others. It could also be that maybe someone needs to just build strength. Strength and mobility changes do take time to get. Next is, will I need surgery? Back to what I said in the original slide, this is ultimately up to the athlete, the rehab specialist, and the orthopedic surgeon. Even something like a complete ACL tear, there are many people that have that ACL tear and are able to go back to whatever their sport is and don't need surgery. Surgery is still the gold standard, but again, there's things that may influence that decision. And then the next question is, when can I return to sport? And really, this is a complicated question, and it's something I'm probably going to go into much further detail in a future video. But what I would say is when someone can return to sport is they have to be able to demonstrate components of the sport without pain, and I can run them through from, you know, easier motions in a closed environment where nobody's around versus, quicker explosive motions where there's other people around, because that's going to change how well that they move. So, uh, back to one of the original questions. People say I have an injury. What do I do? Well, after you've done the physical examination, you've developed the assessment, you've some kind of prognosis. Only then can a rehab specialist really come up with some kind of intervention. And it's my pet peeve where um, people will just do random interventions without necessarily knowing why. Uh, Professionally, I only want to give someone some kind of intervention when I really know what's going on. Here's a list of several interventions. First one is education and activity modification. A lot of times when people have some kind of pain, maybe I just have to modify what they're doing. If it's a sport, such an example, you know, some kind of combat sport, and someone has, I have pain when I throw my hook. Sometimes it could be, hey, I don't want you to throw the hook like this. Either A, if I have that skill, I could try to retrain how they throw their hook, or maybe I say, hey, do this instead. Um, uh, Many healthcare professionals are um, guilty of saying something hurts, don't do that. I would say a more skilled rehab professional will be someone say, don't do that, do this instead, so they can still do either their sport or do their goal. Next is, we always want to do some kind of movement retraining, whether it's we want to work on the mobility, whether we want to do some kind of corrective exercise, something where we feel that there's some isolated joint that doesn't move, or maybe there's some component, some muscle that's weak. We want to add one of those exercises. This is also the next thing is we want to think is from the corrective is that we want to progress people to some kind of functional movement pattern training program, which is usually involving pushing, pulling, carrying, hinging, squatting, lunging. Corrective exercises are used to get people to those functional movement patterns. Sometimes there's rehab specialists that kind of get trapped and they keep their patients in a term rehab purgatory, where all these people are doing is only doing these isolated corrective exercises. But ultimately, especially for an athlete, we want to keep maintaining proper load to keep them functioning on all cylinders. Next, with the skill, in the movement category, would be skill training. Whether it's I need to teach people how to move, or maybe we need to retrain how they're doing their athletic activity. A lot of times, people say that, oh, it's a professional athlete. they must do their skill really well, but a lot of times there could be a component of their sport that they do sloppy and they need to address. I know many fighters that you watch them that move and their punch form isn't really as technically sound as it could be, and maybe that could be contributing to their issue. Uh, Next thing with interventions would be strength, and there's two ways we can look at it. So we could do lower level strengthening, which is which I would use if maybe there's some kind of tissue damage. And this is where there's a term called mechanotransduction, which is what I want to do is I want to stress the tissue to build resiliency. Um, and that's where someone might do these lower level exercises to then slowly rebuild the damaged tissue. It also could be that the next step, which is we actually want to build strength. Maybe someone's just not that strong, or they're not strong enough for what they're doing. Maybe they just happen to be really skilled and move well, and that's how they're able to perform at their level. That's where we would look into actually hypertrophy, building um, muscle endurance, or power. Next intervention would be manual therapy. Again, you really can't do proper manual therapy unless you've done some kind of physical exam with an assessment to know what is going on. There's a lot of different things that I list, whether I use or not, but you really the correct one was based on what you find. You can't try to massage out a joint problem. You can't try to manipulate something that's a skill problem. So even when people come to me for the follow-up videos, I'm always doing a mini exam and assessment before I treat, because I need to make sure that I'm doing the best intervention possible. A lot of times people say, I tried physical therapy, I tried chiropractic, thinking that's the intervention. Really, I would say that a good rehab specialist will look pretty similar. A good chiropractor or physical therapist should be pretty similar in the sense that they may use some kind of manual therapy to then reinforce or gain movement and then retrain that movement. That's generally a philosophy that I would encourage. And then the next intervention is a modality. I'm not going to go into details on my thoughts on modalities, but essentially this would be some kind of pain reduction um, intervention. Uh, they can have a role in different phases of rehab, which I'm going to go into the next slide, but you shouldn't be reliant on modalities. They may play some kind of role, but ultimately when it comes to rehabilitation, the goal is to get people moving and moving well. So now we're looking at the different phases of rehab. And this will kind of dictate what interventions may be best for that athlete. So the first phase, which is acute management, so someone just had the injury. They're in jiu-jitsu and someone did a heel hook and now their knee popped. So usually in this acute phase, someone's going to have some kind of swelling, resting pain, some kind of mobility restriction. Um, this is where I'm going to want to manage that swelling. Swelling, while is an important part of the tissue healing process, when the swelling lingers, that will then limit mobility, generally be more painful, and it's going to impair the ability to develop strength. So I need to get that excessive swelling down. This is also an opportunity where maybe when I did my physical exam, I looked at areas above and below, and I can start to address some of those other injuries. So if let's say someone has a swollen knee, I can't necessarily try to get their knee swollen now. I can't maybe do um, some kind of active exercise. Maybe I can focus on improving their hip function or getting their hip stronger, or maybe getting their ankle moving better, depending on what you find. This is also where modalities would primarily be used. Again, I'm not going to go in detail with modalities and my thoughts on it, but this is where I would use it. Next phase would be that subacute management. So we've addressed it, swelling, resting pain has gone down, but they still have pain and weakness. This is where we start to work on some of those mobility restrictions. We start to work on that motor control. We start to address any asymmetries. This is where I would kind of put the correctives Next phase, which would be phase three. So now we're really focusing on building strength and really correcting those movement patterns. At this point, we should be focusing on more compound motion or integrating um, movements. And the point is then to build strength, movement potential to then get them back to their sport. And then the last phase, which is return to sport, which is where we're working on power development, sport-specific things. This would be, before I clear someone a sport, I want to make sure that they can throw that punch well, or they can jump, or that they can run before I have them actually go back and do the sport. Because when they're doing that activity, there's going to be a lot more chaos. So I have to make sure that they can do it in this closed, comfortable environment before we progress them. This is also where I'm going to do a great exposure to that sport to make sure that they can get there safely. If they can't do it controlled in the clinic, then I definitely know they won't be able to do it when they're in real time.